Thanks, Hatem, for these kind words. Also, thanks to Robert and the entire team in Zurich for inviting me to these rounds and giving me the opportunity to speak to all of you about effects of immune checkpoint inhibitors in terms of cancer therapy and what we can help or see when we perform cardiac MRI on those patients, and potentially also things that we may not know yet, and they may come to light in the coming years. These are my disclosures regarding these presentations. Some of these aspects depend on the administration of compounds, for example, in different regions of the world. So these are going to be the kind of three overarching aspects and points in the agenda. Very briefly, some basic aspects on overall cardiovascular effects of cancer therapy, then diving more into details into immune checkpoint inhibitors. I promise it's not going to be too much details on the pharmacological side because it's becoming very, very complex. And then obviously the focus will be on what can we help with using cardiac imaging, cardiac MRI in the diagnosis of ICI, cardiovascular effects, and potentially also some predictive aspects when we perform MRI. This is just a very brief glossary because there's a few very complex names typically abbreviated. For example, cytotoxicity, lymphocyte-associated protein 4, programmed cell death 1, and programmed cell death ligand 1 are the most common abbreviations you're going to see throughout this presentation when it comes to different types of immune checkpoint inhibitors. There's hundreds of others at the moment, but these are the most important ones, and trying to avoid to speak out the names every single time. In general, regarding cardiovascular effects, it's about cancer therapy-related cardiovascular toxicity. That's kind of the overarching term. And for, I would say, even decades, I guess, the most important effect was what we call now these days cancer therapy-related cardiac dysfunction, or CTRCD, which is decline in LV function, potential heart failure, maybe symptomatic in case you have heart failure, or even asymptomatic, and most commonly caused by toxic effects of anthracycline, or potentially also in combination with other drugs like trastuzumab. Then there's other aspects like vascular toxicity may affect different arteries, different systems, also the coronaries, for example, thrombosis, hyperreactivity, hypercoagulation, hypertension. Some drugs may just result in arrhythmias where imaging obviously is of limited use. And then obviously the topic of today is what's being called ICI, or immune checkpoint inhibitor related myocarditis. And this very, very extensive work from published of the International Society of Cardio-Oncology in 2022 is very, very nice in terms of also overarching principles. And when you look into the likelihood of those effects, you have obviously low, intermediate, and high, and then there's different severities. And unfortunately, the ICI myocarditis is typically, when it happens rarely, but in case it happens, it's actually pretty severe, and the outcome of patients is typically poor. So when we look into ICI and immune checkpoint inhibitors, and we'll briefly explain what the background of these therapies is in a few minutes, most of the effects, I'm not saying all of the effects, but most of the effects are immune-related adverse events, because these immune checkpoint inhibitors obviously tackle the immune system, and then in some aspects, the body's immune system may act against its own cells. The common immune-related adverse events are typically colitis or gastrointestinal toxicities, enteritis, or even gastritis, some skin reactions, or even endocrine toxicities like thyroiditis, hypophysitis affecting the different glands. Then we have those rare but potentially fatal immune-related adverse events, which is affecting the lung, pneumonitis, which is obviously because it's the organ of oxygen exchange, typically fairly severe, neurotoxicity, encephalitis, for example, and then what's really affecting the heart, which is the cardiac toxicity, most commonly myocarditis, in some cases also pericarditis. It's important to keep in mind that ICI myocarditis is not the only potentially cardiovascular events in those therapies. There also may be just dysfunction or arrhythmias without any signs of myocarditis, or something similar to Takotsubo cardiomyopathy, which may, that's not necessarily known yet, also be related to other autoimmune effects like gastritis and then a stress reaction of the body, because we know that Takotsubo is typically a stress cardiomyopathy. And then other immune-related aspects, again, vasculitis, which may affect different organs, where MR could potentially play a role, but it's not going to be the focus of my presentation today. Okay, immune checkpoints and immune checkpoint inhibitors. What are we talking about? And I'm going to very briefly try to explain that. So just imagine, you say you're coming from one country into a country where you need to have a visa, which is a cell coming into a body. And then the body checks whether this cell has a visa for the host. And in case a visa is deemed appropriate and active, it deactivates a T cell, and then it does not kill. In case it's a tumor cell, it would not affect the tumor cell, it would not kill it. And this is typically being done by those, say there's receptors here, and then there's handshake receptors. I call it handshake receptors now here, and PD-1 on the T cell and PD-L1, the ligand, on the other side, in this case, the tumor cells. So in case this happens here, the T cell would not attack the tumor cell. However, in case you would inhibit that passport check or the visa check, you see on the right-hand side, you block on either side, either by an anti-PD-L1 on the tumor cell side or by an anti-PD on the T cell side, the T cell will go ahead and kill the tumor cell. So this is the idea, and this is actually also a noble approach, because in 2018, this kind of discovery has been awarded the Nobel Prize in Physiology or Medicine. So there's some great discoveries behind that. It looks very simple, but it can be quite complicated. But I will not dive deeper into how these things expanding, put it this way. So facts, or maybe not even known facts on ICI myocarditis, very briefly. Mechanism, in general, because of these inhibitors, there is an increased activity of the immune system per se. And it has been shown that there are common T cell receptors or receptor targets on tumors that are alike on those on cardiomyocytes. So the density of the receptors are often on tumors, but also on cardiomyocytes, which then will also act within the myocardium. And it's also known that those CTLA4 and a PD-1 protects the heart of certain immune-mediated damage after stress. This has been done in animal studies, in mice, obviously not yet with imaging beyond that. So there's still a lot of things that need to be discovered, what the approach is. But when you tackle the immune system, sometimes the immune system obviously gets out of the way and may attack its own cells. That's what the background is on these ICI myocarditis. It's essentially similar to an autoimmune disease when the body without a tumor will attack its own cells. The incidence, although it's probably underestimated, is being reported below 1%, slightly above 1%. It's not necessarily known how often it actually may happen, because there might be asymptomatic cases out there that are not being tested for, because the patient never goes to the doctor after initiation of the ICI therapy, and that's why they may not be screened. There are screening studies being performed these days to see, at least on a biochemical level, how often there are changes, for example, in troponins. However, it typically happens, let's say, within the first 4 weeks, 4 to 8 weeks, definitely within 3 months in most of the cases. And unfortunately, in case it happens, the reported mortality is pretty high, up to 50%. It's a low incidence, but the outcome may be poor in many of those patients. Risk factors, obviously, typical cardiovascular risk factors, because it's going to be an inflammation on top of already damaged heart. It's known that in case you combine different ICI therapies, the risk is higher for ICI myocarditis, potentially also pre-existing autoimmune disease, although it is that in most of the study, in the approval studies of those compounds, patients with pre-existing autoimmune disease actually have not been included. It has been an exclusion criteria. So the overall kind of likelihood has not been exactly tested, and things like diabetes as well. This is a slide. Don't worry, no need to look into any details. It's already outdated. It's from 2017. It just shows you, although we have a very, very low likelihood of a patient developing ICI myocarditis, there is just a wave, or I would even call it tsunami, coming upon us on different drugs, which is going in all kinds of different solid tumor chemotherapies. It will dramatically change the map of cancer therapy. I was just looking up again, even in breast cancer, these drugs are being evaluated these days. So although it's a low likelihood, given the potentially very high number of patients, the overall numbers might substantially increase in the next couple of years that we may need to deal with from an oncology, cardio-oncology, or imaging perspective. So let's look a bit more deeper also what we can do with CardioMRI. The toolbox of CardioMRI is not much change. So we have improved our image quality. We have certainly all these kind of different approaches that you see on the slide. Although for any kind of cardiomyopathy or inflammation, flow imaging is not necessarily relevant, and also MR angiography. So it's predominantly function, potentially with additional strain imaging. It's imaging of potential changes in terms of edema based on T2-weighted imaging in lower left, or typical late enhancement imaging or late enhancement imaging that may show you edema as well as deposits or fibrosis. And of course, within recent years, more and more commonly also applications of parametric mapping like T1, T2, or ACV. The other important aspect is there's myocarditis out there, which is not related to ICI, obviously. And over the decades, or the last, let's say, 2 decades, there's been an enormous amount of studies evaluating the benefit of MRI. And that's why the most recent criteria-based published in 2018, the so-called modified Lake-Lewis criteria, is pretty good in terms of sensitivity and specificity in diagnosis of myocarditis per se. There's less data on ICI myocarditis, but the numbers will obviously rise over the next couple of years. The important difference to the first iteration was that now also mappings are being included into the criteria, and in terms of making sure or doing a correct diagnosis, you should have a criteria for myocardial edema, which would either be elevated T2 values on, I call it relaxometry techniques or mapping techniques, or elevated signal on T2-weight imaging, and a sign of non-ischemic injury, which would be LGE, ECB elevation, or native T1 elevation. In case you meet those two, then it's most likely the diagnosis of myocarditis, obviously always in the correct setting. There's some additional criteria. I'm not going to touch into the details. Back to ICI myocarditis, and there is a, let's say, accepted definition of ICI myocarditis based on the International Cardiac Radiology Society. Obviously, you have to have a clinical suspicion. More importantly, the patient needs to be in ICIs. In case there is no ICI therapy, the patient could not have an ICI myocarditis, obviously, with initial tests being the standard ECG, echo, and biochemical tests like troponins. It's also important to exclude potential other reasons for troponin elevation, like myocardial infarction or acute coronary artery disease in this realm. So even CT angiography may play a major role in some of those patients in the initial assessment. And then it's pretty clear, in case you would do a biopsy and have a histopathological diagnosis, the diagnosis of ICI myocarditis is set. But that's a fairly rare event in the initial aspect. Most commonly, it's a clinical diagnosis, and then there needs to be some additional criterions, with the one only possible major criterion being fulfilling all the criteria of the modified Lake-Lewis criteria, where you have non-ischemic injury, T1 based, and myocardial edema, as just shown on the slide regarding the different criteria for the Lake-Lewis criteria. Or in case you do not fulfill all of those, you have to have 2 minor criteria. So a suggestion of potential inflammation by meeting only 1 criteria of Lake-Lewis criteria and some other aspects here. So MR does play a major role in these aspects. I'm going to show you 2 different cases now that were ICI treated patients. You see some details here. So 30 days, so within the 4 weeks I mentioned before. A typical presentation in many of those patients is not like a typical chest pain myocarditis we see quite often, or these STEMI type myocarditis in other types of myocarditis. Often they present only with fatigue and muscle pain. And it's important these days to also educate patients, please come to us, come to your clinic or education by the oncologist in case you feel a change, how you can daily act in these kind of aspects. And this patient even had a normal ECG here, but a massively elevated high sensitive troponin, 15,000 here like initially, and then at the time of MRI, still 12,000. And we see, well, to match the criteria, we see T2 elevation here, we see T2 mapping with some elevated times. On the lower left corner, you see our in-house normal ranges, but even more so, T1 has changed here. And obviously, in case you look at LGE, you see significant LGE on a typical non-ischemic pattern, which is more mid-myocardial to subepicardial. So it meets all the criteria for a diagnosis of myocarditis, in this case, then also a ICI myocarditis. This is the same patient 8.5 months later. It's on 3 Tesla, that's why the values are slightly different. You obviously see residual scar, much smaller than before. Just to mention, ICI was never restarted in these patients, which is one of the major aspects and problems in those patients where MR may have a major impact. I'm coming back to that in a second. In the second case here, where it's not as nice in terms of the criteria, you see some T2 change. Oh, sorry. You see some wrong direction. You see some T2 changes, basal anterior wall here. You see some faint LGE on the phase sensitive inversion recovery, but also some changes, especially on T1. They're all above, pretty much all above 1100, and our normal ranges are, let's say, up to 1050. So it's significantly higher than our normal ranges. T2 is not as significantly elevated, although some of the segments are also higher, especially within the septum here. And one of the added diagnostic criteria, some prominent pericardial effusion and pleural effusion. This was also confirmed by biopsy. To see the troponin in this case was much, much different at the time of the MRI. So it was, the maximum was 19 ever, which is still within normal limits. So it's considered a myocarditis confirmed by endomyocardial biopsy, although the damage to the cardiomyocytes based on a troponin measurement is actually not too massive. Again, a follow-up, we see still residual scar down here, and the values have almost entirely normalized from above 1100 to much closer to 1000. Patient was readmitted after 80 days, but BMR and 6 months later was almost normal, except this residual scar within the apical inferior wall. This is just a brief overview of something that we put together in 4 cases, just to show you a little bit. Native T1 was positive in all of the 4 cases, while not necessarily LGE. And you also see that T2 times are not as, maybe not as sensitive. It's hard to say on 4 cases, but those criteria were not always met based on T2 mapping. There's even more cases with positive T2 signal on T2 stir or spare. Obviously, those cases, typical mapping is not necessarily done covering the entire ventricle, which may also be the reason why not all those cases meet criteria, but it's typically assumed to be a more general myocarditis because it's an immune-related myocarditis other than a virus attacking certain aspects of the myocardium. That's a study from the Marseille group, just to show you and what they did actually, they combined patients from different scanners, and they also had control group. They had patients with viral myocarditis, and they also had a patient group with cancer, but prior to ICR therapy. And you would say, okay, pooling patients on different scanners it's a tricky problem because it's essentially when they're from different vendors. Well, there's one way you can do. You can normalize the individual value to the normal range and get set scores, and then you can pool those data together. It's interestingly, the test score was only 1.8 on average global T1, 0.9 global T2, and you would need to be above 2 to be outside of the normal ranges, and increased only in 36% of the ICI myocarditis cases versus viral. It's actually even worse, similar to what I showed you before for T2. ECV, on the other hand, showed much better values, and they were more often outside the normal range. Keep in mind, above 2 will be above the normal range. However, what's also interesting is that 10% of the free ICI group already had LGE, which means we don't even know what of the LG that we may see may have been there prior to the therapy, or may be affected, or may be the reason or the cause from the ICI myocarditis. From that perspective, I just want to briefly go back to some older data, not on ICI, even on standard viral myocarditis, whatever inflammatory myocarditis, we know there are different patterns. There are those who present almost like an infarct, the STEMI type myocarditis, which show typical LG. Then we have patients who only come with functional impairment, very little changes because they're getting fatigued, because they had they had an infection, and then all of a sudden they developed cardiac dysfunction. And some people only have subtle arrhythmias, but they have a confirmed myocarditis. And when we look into those for terms of MR sensitivity, it's very simple for the STEMI type because we have sensitivity of 80% or even higher sometimes, but it substantially worsens in case the presentation is less specific, maybe sometimes even only subtle arrhythmia, and then MR may not pick up those signs of myocarditis, and the same applies to ICI, obviously. So the performance in terms of the specificity or sensitivity is really depending on kind of symptoms, and most patients here for the ICI myocarditis don't present with STEMI type symptoms. They present with fatigue, as I mentioned at the beginning in these two cases. So fatigue arrhythmia is very non-specific, and then the damage to myocardium may not be as high in terms of overall volume, as then the sensitivity specificity of MRI might be lower. The other aspect certainly is timing. I mean, this is just some, I would say, brief data published in 2020 where the time of admission was correlated to whether the patient had LGE or not LGE, which means in case you do it too early, so the scan, you may not see LGE yet. So in case you scan more than 4 days, 72% had LGE versus 28% had no LGE. And those patients that were scanned below 4 days, it was essentially the other way around. However, this is time from admission. It doesn't really tell you whether there's time from onset of symptoms, so it may not help from that perspective. The second aspect that's important to consider, similar to kind of sometimes in sarcoid, is when did clinicians start anti-inflammatory therapy, like steroids or even maybe immunosuppressive agents to start the therapy in those patients? Obviously, they also have an impact on findings in CardioMR. So the challenges that we face in these days is obviously kind of, do we have a high specificity, high sensitivity? Biopsy obviously gives you the final result, although there's still some bias based on the fact where you perform the biopsy, although it's supposed to be a more global effect rather than a focal inflammation that we see more commonly for viral myocarditis. Specificity is also pretty high in case MR or imaging meets all the Lake Lewis criteria. So a positive T1 sign, a positive T2 sign. So then you can be pretty confident. But once this is not there and you only have one of those criteria met, the specificity obviously drops and sensitivity gets higher. And then it's even more challenging in case you have symptomatic patients, only that some subtle changes in ECG and arrhythmia, where MRI may not show you a clear positive finding. This is something that we need to keep in mind. A little bit regarding prognosis. These data are based on registries, where it was shown essentially that the presence of LGE did not necessarily predict a better or worse outcome in the follow-up, while there was some differences for T2, but not necessarily as we would like. There's some differences, but not substantially after a longer follow-up. That's a little bit different in case you look into mapping aspects. That's also registered data, which applied similar methods because they were all from different field strengths, from different vendors, from different centers, where we indexed the local or the patient's values to local normal ranges and then applied the set value indexation. So you see whether it's above 2 set values off or it's within normal ranges. And when you look at that, although there is no significant difference in the longer follow-up for T2, for T1, there's clearly a benefit, or there's clearly a difference in terms of outcome in case you have T1 that's more than 2 deviations above normal average or normal mean, which means you're outside of normal ranges, the outcome of those patients is worse. Although it means those patients would meet, in this sentence, they would meet the T1 criteria for inflammation. It means it's confirmation of a myocarditis. So what's going to happen in the next couple of years? So these therapies are kind of exploding. So it's hard to really follow. It's going into all different kind of tumor settings. There's more combination therapies, and I mentioned it earlier. Combination of different ICIs elevate the risk of ICI myocarditis. There's next generation ICIs that may have different effects on the immune system. So it's definitely moving to the front line. It will be a main player in chemo or in cancer therapy in the next coming years. And I think from the diagnostic aspect, we need to be prepared to face this challenge. And often those patients are not coming in as an outpatient exam. They're coming in as an urgent inpatient exam because patients have been admitted. And early changes in therapy are important to potentially save the patient's lives in case developed ICI myocarditis. It's clearly being recommended to perform MR for the assessment of possible or diagnosis of possible ICI myocarditis. It's also in the 2022 guidelines in cardio-oncology. It's a #1 indication, so there's no doubt that this is definitely indicated from a perspective. Just a fair warning, in any case you rely on mapping these days, a lot of people rely on mapping is really look at your images first before you draw any value from anything. You see the map on the right-hand side where you have some blurring in the map in case you just draw something in the inferior septum here. Whatever value you get, you should never use that value, because when you look back into the motion-corrected images, you see that some of the images where you see the septum very close to the border here, and some of them are very central. And the map on the right-hand side is nothing else than putting all those images on top of each other. So always check in any single case, ICI myocarditis, cardiomyopathy, really check the quality of your images, whether you can use those data, because otherwise you may come to an incorrect conclusion, which may terminate the patient's chemotherapy or result in inadequate therapy because the patient has a myocarditis, but you cannot call it. The second aspect is, especially on 3 Tesla, most centers use SSFP readouts. And in case you see things like here on the right-hand side, this is not an ICI case, but just a general case, it's important to look at other things. And SSFP is prone to artifacts. When you look at the source images, this is an artificially low T1 value because of these artifacts. So be aware that those things may happen, and do a quality check before you really rely on these aspects, because it may or may be the wrong call you make on a patient's case. Last slide. So a few take-home points. ICI therapy approaches will just continue to grow, and we are really, really only at the start. CardioMR is with no doubt an important tool in the establishing ICI myocarditis. There's some somewhat limited data with respect to the diagnostic performance. It's assumed to be a bit less sensitive than in inflammatory or viral myocarditis. The qualitative measures like LGT2 have some limited added predictive value, but we all know that in case you establish it, the outcome might be detrimental anyway. So high mortality. Among the quantitative measures, so on the mapping measures, I would say T1 has the best predictive value. And important to keep in mind, we need high quality data to interpret correctly the images that we get. It's not about just confirming a diagnosis that's clinically already assumed. We need to be the critical judge, as always. And I think it's also important to keep in mind, and that's similar to a viral myocarditis, but the effect might not be as big. You can't necessarily rule out ICI myocarditis on negative cardiac MRI. And those patients often, at this moment at least, move on to an myocardial biopsy in case there's still the clinical suspicion of ICI myocarditis. And with that, I'm at the end, and I thank you for attention.